I'm Dr. Tran. I practice in Orange County, California, and my company or my practice is Coastal Vision Medical Group. It's based in Orange County, California. As you know, the light adjustable lens could be adjusted after the procedure to get the desirable refractive outcome. So the question is, does the femtosecond laser contributing anything to the whole visual outcome process? It does a really nice capsulotomy, and previous studies have shown that potentially it may help to get more predictable effective lens position or ELP, thereby maybe improving the refractive outcome in conventional intraocular lenses. With light adjustable lens, we'll be able to adjust the refractive errors out in any case, whether the initial target is right on or not. So is there any benefit of using the femtosecond laser in the light adjustable lens next replacement? So that's the motivation behind what we're doing in looking at the data, the visual outcome. And one of the criteria we look at is actually help to reduce the number of light adjustment with the light delivery devices, and thereby reducing the chair time and more happy patients and more convenient for patients. As you know, the femtosecond laser can make a capsulotomy at the precise locations using a three-dimensional reconstructions of the lens and calculating the centroid and try to place a capsulotomy as central to the vertex of the lens, so the center of the lens as much as possible. The combination of the uniformity of location, size, shape, and locations potentially give us a little bit more predictable in terms of the predictability than affected lens position, perhaps because of the precise shape and size locations, the vector forces pulling on the lenses and so on. As the eye heal and the capsule contracted and healing, the forces are more uniform and allow us to potentially translate it to something more predictable and translate it to better visual outcome. So we have a group of patients that chooses to have the femtosecond laser with their surgery due to some of the potential benefit of the laser. And then there's some other patient who choose not to have it because they understand that the light adjustment can negate out the potential refractive error in any case. It certainly costs less to do the procedure without the femtosecond laser, and whether the benefit is there or not is not quite proven either way. So some patient would choose to have the procedure with less cost without a femtosecond laser. And we look at retrospectively the result with the two groups. Consecutive eye cases surgery with femtosecond laser, light adjustable lens versus manual capsulotomy with the light adjustable lens. The majority of the patients chose the femtosecond laser. It was almost like a 3-to-1. We have about 80 something patient that chose the femtosecond laser versus 20 something patient that chose almost 30 patient chose the manual capsulotomy. And the key thing is, what is the visual outcome right after the surgery before the light adjustment? So we found that the percentage of patients within a quarter adopters is higher in the femtosecond laser group prior to any treatment. It's almost 2/3 versus half of the patient in the manual group. And then the percent of patients that within half of the diopter is also higher on the femtosecond laser group. It's almost 90%, it's high 88% or so, versus a 71-72% in the manual group, which is consistent with some of the results that we've seen in the literature. This is before the light adjustment. After the light adjustment, the average number of light adjustment were the same within the two groups. So 1.5 for the femtosecond laser and 1.6 for the manual group. So it's not statistically significant, it's about the same. But what's interesting is about 3% of the patients have less number of adjustment with the femtosecond laser group. So they only require one treatment. And then obviously 3% of the patient in the manual group require more treatment in the 3 treatment range. The number difference is small, but it's not statistically significant between that after the treatment. However, as you look at it, if you do about 100 cases, there's going to be about 3-4 patients that have less treatment. So it's favor the femtosecond laser group a little bit more than the manual group. Both have happy result. They're very happy with the results. But if you're looking for a little bit less chair time, it seems like the femtosecond laser group produce a little bit more precise refractive outcome to start with, and a little bit less number of treatment after the procedure, like adjustable lenses there. Another interesting finding that we find also is the percent of patients that have very accurate cylinder result or astigmatism correction seem to favor the femtosecond laser group. Now, knowing that sometimes we may not go after every single amount or every small amount cylinder, because the whole concept behind light adjustable lens is the balance between the clarity of focus in focus by hitting the exact refractive outcome after the treatment versus the range of focus by leaving a little bit of cylinder behind or a little bit of refractive error behind to give the patient full range of vision, the distant, near, and intermediate versus higher clarity at one range of vision and less at the other. So it's balanced game that we playing with lens surgery in any lenses. But in the light adjustable lens, we're able to customize that and to allow the patient to experience that and give us feedback. And some patients would choose to stop the treatment right before the final number targeting that we have because they're happy with the results. So the absolute number is not as important as the difference between the two groups. But we found that with the femtosecond laser group, the higher percentage of patients actually hit the refractive outcome that we planned for patient. Now they're both happy. Sometimes they don't hit it, but they're happy because of range of focus. But it would be nice if we hit it. So it seems to be a little higher, especially on the cylinder. It's about 10% different between the two groups.